Morning. Welcome to another session of critical appraisal. So, especially for the benefit of registrars and interns, usually we would have looked at study designs like a randomized control trial or a cohort study, where you will be studying two interventions or one control and one intervention and see what is the net benefit. But in real clinical practice, it may not be as simple as that. Sometimes you may have to choose one among two strategies. Say, for example, what do I do? Whether I test for this patient or whether shall I just follow up this patient? Suppose a patient comes with fever for 3-4 days, whether I evaluate him for a PUO or just observe for a few more days before I start evaluating for a PUO. And then what is the net benefit that you are going to observe over a period of time? So when you are having to take a decision whether you need to go with one pathway or another pathway, there is a modified study design, which is what is called as decision analysis. So today, Dr. Nivin will take you through one such critical appraisal of a decision analysis study. He has made some introductory slides to tell you about the basics of decision analysis and some of the terminologies that have been used in this article. And following which he will take you through the critical appraisal. Yes, but a lot of effort in making those slides. So I'll hand over to Dr. Nivin. Thank you.
Thank you, sir. So yes, as sir mentioned, we do a lot of decision making in our day-to-day practice. So how do we critically appraise that is something that I will be covering today. So let's start with the case scenario first. Okay, so you are the intern on call. Okay, and the nurse calls you saying that Mr. R is having sudden onset breathlessness. His saturation is 92%, respiratory rate is 30, BP is 150/90, and the JBP appears to be elevated. You order, as per protocol, you would go ahead and do ECG, X-ray, EBG, and then what would you do next? Rakshita, since you're the only intern here, what would you do next after this? Okay, CKMB, that's one. Something else? Okay, that's something you could do. Anything else? So yeah, that you're right. So one thing you would do is also call your third call. So third call may, depending on who it is, may answer your call, may not answer your call. That's another thing, depending on the registrar. What do the registrars want to do? He said CKMB. So CKMB is one. So if you do CKMB, you can either diagnose probably an NSTEMI patient as an NSTEMI. If CKMB is and top is negative, then probably you think of PE. You go ahead, either do a CTP or you say, okay, no, I'll just do a D-dimer first. The well score is less. Otherwise, you may give PASIX. Patient may get better, patient may get worse. Anything else? Yes. Sorry, BiPAP. Yeah, that's true. BiPAP is another thing. What is the patient may worsen? You may start BiPAP. That's another thing. Person third call does not answer, then what you do? That's not unheard of. I mean, it's possible. Yeah, so you try to call the fourth call, exactly. So you call the fourth call. I think there are no other instances with I have to target all the questions. Or you may send the attendant to MIQ. You may decide to treat, like you said, CKMB. You may say, okay, I'll try with furosemide. A similar patient had this complaint. I will give furosemide and see. Patient may get better, may get worse. Or you may decide to do nothing. That's entirely up to you. Okay, so this is just an example of a decision tree. So you have multiple decisions. You can either choose to do an investigation or decide to treat. And there's always a probability assigned. So the probability that he answered, okay, maybe 95%, maybe he didn't answer 5%. Whether you call the fourth call, again, that depends on your personal opinion and how whether you would want to talk to the fourth call at that point of time. Those are all things that you would think of. So medical decision making is always quite complex. So always we kind of have some mental clues that we follow. So heuristics is what we usually follow. In a busy OPD, elderly lady comes to you, whether you should start her on warfarin, okay, you quickly look at her and say, okay, she looks failed. I'm not going to start anticoagulation if she has a EF. So these are quick decisions that you make. But on a large scale, and you're looking at, I mean, you may make small mistakes, or you may kind of misjudge your harms and benefits of the specific intervention. So probably in that patient, giving warfarin may have benefited. Another example is latent TB testing. Okay, so is it worth testing patients for TB? So again, we have different things. So either you can decide to treat, you can, test. You can test with an IGRA, or you can do no testing. If you test with IGRA, you can either have an IGRA positive or an IGRA negative. The IGRA is positive, again, it could be a true positive, or it could be false positive. So again, as it goes on, if it comes to positive, you decide, okay, am I going to treat? Am I not going to treat? Amongst those who treat, you again, they may develop drug-induced hepatitis, some may not develop hepatitis, some may actually even die due to hepatitis, some may survive. So this is an example of a slightly more complex decision tree. So what we need to know is each point is a node. Okay, so we start off with a square node, which is a decision node. And subsequently, we have a chance node. So at each blue dot or a circular node, we have a chance. So there's a probability assigned to that. And then subsequently, we go down till we get the triangle node, which is a terminal node. So at the end, we kind of say, okay, patient dies, okay, there's no more going from that. Or the patient survives. And this is at a point of time, these are the different decisions that can happen. So the aim of this is, it kind of helps us rationally weigh out each of the possibilities, and kind of we can assign cost effectiveness. So we can assign something like cost. Okay, I have paid 2,000 for an IGRA versus 0 for no testing. Like that, you can kind of map out the cost and give us an idea which is probably the best course that we should take as a decision maker. So again, probabilities you can assign. So the important thing is you need to know that each probability should be independent of each other and it should kind of add up to 1. So here, let's look at this. The utility score of 1, so that means perfect health, or he can survive and have good outcomes, whereas 0 is kind of death. Can go backwards. So here also active TB, no TB, 90% versus 10%. So like that, in each node, we can kind of put a probability point also. So all these probabilities that we get, where do we get that from? So we get it from prior existing knowledge, from our prior RCTs that could be done, like we discussed last time. RCTs can have good internal validity, but the external validity may not be so great, or it can be done from meta-analysis or from observational data or whatever administrative database that we have. If we don't have any of this, we may have to rely on expert opinion, some panel opinions, things like that. So that is your decision tree model. Secondly, so one thing is patients may not just fit in one thing. So once they go to latent TB, for example, they don't have TB, they don't have latent TB here. There's no, we do here, the IGRA negative. So then later on they can become IGRA positive. So patients don't really stay in one health state. They may kind of transition through different states. So one thing to help us is this Markov model. So this is the bubble diagram. So patients who have, for example, hypertension, those who have hypertension, they can be alive without a stroke, or they can have an MI. So that is one state. These people can go on to develop stroke, or they can develop MI. So after stroke, or they may die. Same thing for MI. Those who are having MI can have a post-MI, they can continue to be post-MI, or they can kind of expire. So the state transition model accounts for the fact that people have different parts of disease and consists of mutually exclusive and exhaustive health states. Okay, so defined by the disease and the treatment characteristics. So we can kind of assign our own probabilities. Okay, patient 95% that he continues to stay in the alive state, 2% may develop stroke, 3% may develop MI. So look at that is one cycle. Then the next cycle is in the patient who had the stroke, 5% may have a repeat stroke, 75 went on to have post-stroke, they had deficits, whereas 20% may have gone on to die. So like this, if you run the model multiple times and you are able to find out how many people are there in the stroke arm, how many are there in the post-stroke arm, how many people are alive, how many people are dead. Of course, the cycle will go on till all patients are dead. So you have to model the Markov model accordingly. Okay, so this is called a bubble map, and each patient should reside only in one health state. So this is an example of cost effectiveness of an immunotherapy plus chemotherapy. So we have your base care arm, which is placebo. This is for advanced non-small cell lung cancer. So we have a placebo arm with chemotherapy, and then there is the immunotherapy arm. So then they go on to the Markov model, and they can have a progression-free survival. They can go on to have progress disease, or they can have death. And then you have this, they can go through between each state. Okay, so this is just an example. So we have a decision node, the Markov node, which is again patients going through different states, chance node, and then the terminal node when patients on the end of the study. So that is one way of showing the Markov model. The other way is similar to this. So we have Markov node. So it doesn't have to be just two. It could be patient can be alive with TB free, patient can be alive with TB, they could have cured TB, TB death, other death, or totally unrelated death. And then again, you kind of branch out. So as you have more branches, the sensitivity analysis becomes more and more difficult. So it should be complex enough to mirror that reality, but not too complicated also. And we kind of assign probabilities to each likely state, and then we run the simulation to kind of find out what are the long-term effects of each different decision. So at the end, we can find out in this, if we run the model, we can kind of find out what is the long-term impact of TB screening and treatment as opposed to not treating. So we find the cause, side effects of the therapy versus probability of developing active TB or disease or death due to the disease. So when do you kind of decide to do a decision analysis? So it's always in this uncertainty, like Sir mentioned. We may find the best RCT which may show that the drug works, but will we use it in our day-to-day practice? That's what we need to kind of you look at with help of a decision analysis. When there's uncertainty, and there's always a trade-off between different strategies. So there's always some benefit, some risk. So what is your economic evaluation of your intervention, what you're looking at? For example, if going back to this elderly lady with atrial fibrillation, the giving warfarin may reduce the incidence of developing embolic stroke, but again, definitely we know that it increases the bleeding risk, especially if the patient has a high hazard score. Doing an MRI in UK or Britain and all may be cost effective in their scenario, but whether it's cost effective in our secondary care center or mission hospital, that's something that we need to look at. So we're looking at the economic impact of an intervention. So going to a few terms that we need to know. One is cost-effective analysis. This is looking at clinical measures or life years. So you did the intervention, so patient was supposed to live for 20 years, patient has gone on to live for 30, so you have gained 10 years. Then cost utility is when it's looking at another two-dimensional measure, that is quality-adjusted life years, or DALYs, that is this disability-adjusted life years, that is averted. Or we can look at the cost-benefit. When we convert those qualities into monetary terms, we kind of call it as cost-benefit analysis. Overall, we're again looking at the economic impact, that is cost effectiveness. So just a small bit on qualities. So we can either have, for example, if you don't look at this, we have if we didn't do the intervention, patient dies here. With the intervention, patient dies here. What quality adds on is the quality of life. So 0 being dead and perfect health being 1. So if with the intervention, without the intervention, patient would have had significantly dropped the quality of life, then again expired here. But with the intervention, patient goes on to have additional quality, and then so it kind of gives us a two-dimensional model. Okay. So that's important because not all interventions may actually improve your life years saved. Some may actually improve the quality. Some may kind of go opposite also. So it kind of gives you, okay, quantity and quality, so morbidity and mortality of the intervention. How does it improve? And we can kind of compare this across interventions and disease. Another thing that is commonly used is DALY, so disability adjusted life years. So patient is healthy, develops the disease. So how many years does he live with the disease? And then he had an early death because of the disease. So how many years of life was lost is what it looks at. So it's similar to poly, but it's not exactly the same. So another important thing is cost effectiveness. So when we have a strategy, we're always looking at this graph, okay, the cost effectiveness plane. So this on the y-axis, we have the cost. And on the x-axis, we have the effect. So let's assume this is an example of MI. Patient comes through with MI. Let's assume A is probably doing angioplasty. So the cost of doing angioplasty is around 0.6. Okay, so that's reasonably good. Let's assume B is doing a coronary artery bypass graft. So definitely it's more expensive, 15,000, but the poly gain is much more. Okay, so we have a more costly intervention, but it's more effective. Whereas if it was in this arm, it would be less costly, but more effective. What about this? Less costly, less effective. Anything? Any intervention registrars that you can think of in this example? MI, angioplasty, CABG probably is that side. What is on this side? Yeah, medical care or doing thrombolysis. So that would lie somewhere here. So you have a trade-off between it's less costly, definitely, but it's also less effective. So there are two other things that we need to know. If it lies on this arm, so it's clearly dominated. So it's more costly but less effective. This is probably a strategy we would not want to use. Whereas here, so what we want all our interventions to usually like this, but it may not always be. So this is less costly and more effective. This is what we're looking for. So how do we decide? How is the decision maker going to decide? It depends on their willingness to pay. So this shaded area is the willingness to pay. Below the of which, okay, here obviously you would, but if it's in these two arms, then you would decide, okay, how much more are you willing to pay for that increased effectiveness? Whereas here, okay, how much can you trade up or less? Which of course there's less cost here, but how much effectiveness are you willing to kind of give up for? Okay, so I'll come back. So it looks at overall the social return on investment and the willingness to pay. I will kind of touch on later on as well. So how do we use that in real life scenarios? So another important topic is this ICER. Okay, so this is the incremental cost effective ratio. So if you look at this, this is the cost and the effectiveness. You get the slope. And if you want to compare 2 points, you kind of, I mean, 2 interventions, you do this ICER calculation, which is the cost of your experimental therapy minus the cost of the control or what you're routinely using divided by the Qualis gain that you get. So based on that, you kind of decide the ICER value. And lower the ICER, the more cost effective it would be compared to base care. So what are the steps in doing a decision analysis when you want to do it? So first, of course, we'll have to formulate a clear research question. So the question should have be targeted to a specific group of patients. It should have a relevant to the clinical decision that you're trying to make, and it should have significant alternatives. So there should be an intervention and there should be alternatives. If you miss out an alternative, then it may lead to misleading results of cost effectiveness. For example, in that previous example, if you left out angioplasty, if you left out thrombolysis, then you kind of get a false impression that, okay, CBG may be better or angioplasty might be less cost effective. So those are things that we need to account for. We need to kind of look at all the alternative course of action. Then you kind of construct a decision tree with decision branches and different nodes that are there, representing the occurrence or non-occurrence of your relevant outcomes that you're looking at. Then you decide whether are you looking at it at one point of time or are you looking at over a period of time. Then you may have to incorporate a Markov model. If you're using that, how long are you going to run your model for? Are you going to run it infinitely? Then probably doesn't make sense. So you'll have to do it as, for example, the life of the patient. Like that, you'll have to kind of model it accordingly. Okay, so is it an appropriate cycle length that you're looking at? So I just showed this model. Running the model is also quite, it's not so complicated. You can kind of do it on Excel as well. So running this, so you have actually, we are hidden next. So this is, sorry for the interruption. So yeah, so we can actually run a Markov model, I mean, this is just a simplified version of it. So we have three states. So either person can be healthy, person can be diseased, or can be dead. So if the person is healthy, I mean, you assume 96% are healthy, 3% go on to be diseased, and you start off with zero as dead. Then slowly as it goes on, some people get disease, some people go on to die. Then you can also write the payoffs. Okay, so the cost for being healthy is around $50. If you become diseased, cost becomes 1,000. If you're healthy, the QALYs is 0.9. If you're diseased, the QALYs drops down to 0.6. So then you can write this number of cycles that you want. So each cycle can be either a month, it can be either a week, it can be the year. So you can model it as many years as you want. And then start off with healthy. 1,000 people usually start off with 1,000, 0 disease, and then dead. And then you kind of run it down. You just multiply it with your probabilities here, and then you kind of get how many people will be in each arm. So, for example, on the 23rd cycle, these many people will be there in one arm, second arm, third arm. Then you look at what is the cost. Cost of being healthy is you start off with 1,000. Then it becomes you start off with cost is 50. Then you get 50,000. And then you kind of, as you get more disease, you kind of can increase the cost. Then you look at the number of QALYs, you multiply that, and then you can kind of make the number of QALYs gain. And ultimately, at the end of your model, we can say, okay, this is the total cost average per person per capita, and the QALYs. And then we're kind of able to calculate, okay, this is the ICER value for your intervention. So this is just an example, and there are multiple YouTube videos online. Yes.
This is for one decision. If I made one decision, this is what will happen.
Yeah.
And then you can change
based on the probability
of healthy disease, then we can see that.
Yes. So how many QALYs gain, what is the cost, and then you can kind of run it. Yeah, so it's easy to run that model, but it gets more and more complicated if you add more and more variables. Because diseases aren't always so fixed. Maybe for example, if you're looking at TB, latent TB, again, after contact with another person, the probability might be quite high, but after 10 years, the probability goes down. So it's always not very fixed. So there are a lot of adjustments that you may have to do. And even if you're looking at time, you may have to look at inflation, discounting, multiple other things that you have to look at. So we also need to know what perspective are we looking at. Okay, that's a very important aspect. Are we looking at it from the patient's point of view, hospital, healthcare point of view? Are we looking at it from a societal point of view? Patient may worry about, okay, how much can he spend based on his income? So what are the direct costs? Okay, the test is going to cost 1,000 rupees. What are the indirect costs associated with it? He lost pay, he has to need someone to travel, transport, all those indirect costs also are something that he would be worried about, or he or she would be worried about. Provider would be more worried about, okay, how much am I willing to spend? You have to spend for multiple costs. So it could be minor costs or there could be gross costs. So minor costs would be things like, okay, you have to pay for additional healthcare staff, air conditioning for a particular intervention like an MRI. So multiple things that you'll have to look at. Whereas you're looking at societal benefit would be, again, including what is the overall benefit to the society. So improved disease transmission, again, can kind of improve the quality of health overall. Then usually we look at the payer perspective, but which may not be always right. If you're looking at it from an example, sir mentioned last time, AI had said that if you kind of allocate resources to the white population, you get better QALYs. So that may not be, from the payer's perspective, that makes sense, but from a societal benefit point of view, it does not really make sense. So that's one example I wanted to mention. Then if we are involving only individuals, then we should look at make the model in such a way that it's only outcomes that the patients are interested at are involved. They may not be really worried about, okay, what does the system cost and what is the cost otherwise. Then we kind of identify the probabilities looking at the literature, and we conduct literature search and kind of inform all the probabilities and the utility scores that are there. Okay, and then we kind of fold back. Okay, so this is another example of in Coimbatore using ceftriaxone which versus levofloxacin for a hospital-acquired infection. So what is more cost-effective? So here we see that definitely the cost of levofloxacin is much more, and we have higher success rate. Cost of ceftriaxone is much less, so $0.96, but there's higher failure. Go backwards. So here cost would be 1.06, $1.77. So overall cost-wise, it appears that ceftriaxone seems to be more cost effective. This is in terms of cost. If you're looking in terms of utility scores of quality, so one being perfectly expired, we go back and adding on the probability. So here the probability of good utility score is 0.99 into 1. Then you kind of go back, you take and you include, you multiply these two probabilities, then you kind of go backwards. And ultimately, we kind of come with this utility score. So if you test for latent TB, the score becomes 0.9992, whereas here it is 0.999. So it appears that in this study, no latent TB kind of is more cost effective. So this is a way of holding back at the end. And at the end, we kind of do a sensitivity analysis to see how uncertain are your results and how robust are your results. So coming to a case scenario, so you have Mr. X, he's a 45-year-old gentleman, he comes to your clinic for a general checkup. He recently read this in the newspaper, which said that there's a huge burden of TB in our population. Estimated mortality is also quite high. He's quite worried about his health. He has a history of being incarcerated 6 years prior, and he was incarcerated for 6 months. So he wonders, okay, whether treating him or testing, would it help or not? So again, amongst those who are incarcerated, the data is quite scarce. In Brazil, around 20 times higher. They have a large prison population, so the incidence of TB is quite high compared to the general population, nearly 20 times. In India, some studies show up to 5 times, and kind of acts as an institutional amplifier. So this is a lot of overcrowding, there's poor ventilation, poor access to healthcare, even delayed diagnosis, which could kind of spread the disease. More high-risk factors maybe there, like undernutrition, other comorbid conditions, illicit drug use. So multiple things that kind of cause being incarcerated to be a risk factor for developing TB. So he's worried about his health. What would you do next? So we looked at this study. So this is published in Lancet in September. This is the cost effectiveness and health impact of testing for TB infection, not disease, among formerly incarcerated individuals in Brazil. And they used a Markov modeling study. Okay, so we'll go ahead and see what we did, how they proceeded. And I'll be using this user guide to medical decision analysis by the Mayo Clinic, which kind of critically appraises it, similar to what we use for other, with slight difference, other designs with slight differences. So the main questions again would be, are my results valid? What are the results and how do I apply it to my population? So it starts off with first judgment. So the first judgment is evaluate the credibility of the decision analysis, methods of the decision analysis. Was there a clearly fixed research question that was there? What was the population that they looked at? What were the outcomes that they looked at? So again, like we mentioned, there should be a clearly actionable intervention. There should be multiple alternatives which should make sense and should be relevant in the clinical decision making. The outcomes that we look at should be relevant to patient care. Okay, so it should be either mortality, qualities, not or functional outcomes, not some surrogate marker like, okay, include bone health or lipid levels, something like that. Okay, and it should include everything and kind of not miss out things, otherwise it kind of reduces the trustworthiness of the report. So the population of individuals who were formerly incarcerated, the intervention was a TB infection screening strategy, and then you start preventive therapy. C is no screening, and the outcomes that they looked at was the health benefits. So reduction in the TB attributable DALYs is the main thing that they looked at. They also looked at the number of TB cases and deaths that were averted per 1,000 individuals. They looked at the ICER and the cost per DALY averted. So what seems to be missing here? Registrars. Are you happy with this question, or do you want to look at other things also? Anything else? Rajesh, anything? Amongst the outcomes, so you're looking at any other outcomes that you think they should have looked at? This the quality of. Yeah, qualities they have not. So usually for lower middle income countries, they kind of use DALYs instead of qualities. Kind of similar, but not exactly same. But so one thing that they missed out is they kind of forgot about the possible side effects of starting preventive therapy. How many people got side effects? They didn't look at the side effects of the preventive therapy. On the positive side, one TB patient can kind of infect 10 to 15 patients is what they say. So how many overall what is the societal benefit also, that may have been difficult to calculate. Okay, so
How long was
yeah, so this
it? May not be the same if they were incarcerated 1 year versus
Yeah.
10 years.
that's true. So that also they've kind of looked at later on. They have done some small adjustments for that. Yeah, so the testing strategy was either do a tuberculous skin test or you do an IGRA. The 4 treatment regimens is you give 1 month of isoniazid and rifampicin, 3 months of isoniazid rifampicin, that is weekly dose, 900 milligram, then 4 months of rifampicin every day, or 9 months of isoniazid every day. So these are different strategies that they use, and they kind of use different strategies, combinations of each test and regimen. So TST with this, TST with that, because there's multiple things. So I mentioned about willingness to pay. Yeah, so I mentioned something about willingness to pay. So that is, for an intervention to be cost effective, the ICER should be lower than your local cost effective threshold. Then only you can say, okay, I'm going to go ahead. So the government, how are they going to approve it? Only if the ICER is going to be, you're showing that it's going to be cost effective. So usually we used to use this, the WHO used to say, it is cost effective, if very cost effective, it is if 1 tally is awarded per 1 GDP per capita. Then cost effective if it is 3 into the GDP per capita. This has been widely cited, but kind of has been the established norm, but it's just an abstract number and did not reflect the health opportunity cost. So what is opportunity cost? Anyone wants to say what opportunity cost is? Registrar with an opportunity cost. For example, I'll give an example. So for example, you are here doing the course. You have paid significant amount for tuition fees, multiple other things. So the opportunity cost would have been in case you had gone and worked elsewhere and earned some other money from doing something else. That is the opportunity cost. So that is things that you could have actually done. So if you had 100 rupees, you could have gone, watched a movie, gone out for dinner. So these are the opportunity costs that are involved. So the money that you're going to put for an intervention for the government to, for example, if the government decides the next day that they are going to test everyone for latent TB, that money has to come from somewhere. So that has to come from either you take it from not chlorinating water, or not giving doxycycline, or not giving vaccination. So that money has to kind of come from somewhere. That is, you're looking at the opportunity cost. So what this BMJ article said, and this is what the study quoted at, they said that it should be close to the GBP, and they kind of made a model, and they said that for Brazil, the number should be close to $8,000, which is around 98% of the per capita GDP for it to be significant. So they had done different models, so DALI 1, DALI 2, DALI 3. So close to around 8,000 was the cutoff that they took for saying that it's significant. So I'll come to India also later on in this talk. So that kind of implies that for an intervention to be cost effective, it had to be below this threshold of 6,300 to close to 8,000. So 8,917 it should have reached. So if screening for patients with TB was less than this, then it would prove to be cost effective. Okay. And the interventions were dominated if they had higher cost and worth. So it will be dominated as opposed to dominant if it was poor down. So what are the time horizons that they looked at? They looked at whole lifestyle of the study cohort. So if there are 1,000 individuals, the whole lifestyle they looked at for total number of TB cases, number of TB deaths, and life years spent with TB. So this is the decision tree, which is a simplified model. So they do a one-time screening for TB. You screen for TB infection. So if you have infected, some of them may be lost to follow-up, so you don't give them preventive therapy. Those who are negative, again, no infection detected, you don't give therapy. Those who turn positive, you decide, okay, you test for TB. Do they have the TB disease or not? If they test the disease, again, you give WHO recommended standard therapy. If they're negative, they diagnose it with infection, and then you kind of decide, okay, some of them may again be lost to follow. Some of them you may want to start therapy for. So those who are tested positive start treatment. So this is one arm. The second arm would be a base case scenario where you don't do anything at all. So you don't do any screening. That's the second part of the decision tree. So they didn't do this. They went ahead into Markov modeling. So they have patients who are uninfected. You can go on to have, so the black arrow shows this is a natural progression of the disease, whereas the red is reinfection. So uninfected, you can go on to have latent TB where it's there in your body for a long time and you kind of clear it, or you can go on to have fast TB where it kind of is more aggressive and kind of spreads faster and you kind of develop undiagnosed TB. Then you can either recover or you can go back to being undiagnosed again. Then you can go to get disease, which is diagnosed, you can recover, you can go on like that. Of course, and then there are some proportion that go on with that. So you can't go back from that. So you just run the model multiple times based on the probability that is there. So where did they get these probability numbers from? That's what we need to look at next. So based, like Sir keeps mentioning, GIGO, so garbage in, garbage out. So we kind of need to know where did they get these numbers from. So they have multiple probabilities here. They have mentioned the 95% uncertainty interval. So where did they get that from? This Pepin et al. Was again, the first thing, probability that my MTB results is positive. Patients, probability of return of MTB infection results. Again, they quoted some studies. This again is based on another large, it's an Indian study looking at patients who had latent TB infection. Okay, so this looked at multiple diagnostic tests looking at, this is quantiferon gold. It's interesting to note that there's an Indian study that was in 2007, which was not industry funded in Mahatma Gandhi Institute, and that's kind of showed that the sensitivity was close to 73 to 79% sensitivity. So overall, the results from that shows that there is some amount of, external validities can be improved because it had some amount of Indians in that probability point. Then subsequently, other things that they looked at, Stephan et al., like I mentioned, was a systematic review, meta-analysis. Then they looked at this Doan et al. Was a Bayesian latent class model that looked at multiple diagnostic studies. Zhang et al. Was a systematic review, had 3 Indian studies also. Okay, then this WHO one, the specificity of initial TB screening was actually another modified Delphi method. So in the hierarchy, we would kind of put that quite lower down. Then Sterling et al. Was again a systematic review. There was an RCT, the Swindles was an RCT, and the last would be a retrospective cohort. So we kind of put a hierarchy and see what is the quality of evidence. So they have not really specifically mentioned what is the grade of each evidence, but we know that, okay, systematic review, meta-analysis is quite high, and that too involving Indian studies would be useful for us. And slowly as we go down, we have RCTs, then we have diagnostic studies, then cohorts, and then we have the last, we have a modified Delphi method that is just kind of the expert opinion. So so far it seems like we have significant data for these test and preventive therapy parameters. So this is the efficacy of each parameter, sensitivity, specificity, all that seems to be based on hard kind of data that is there. Then comes the disease progression parameter. So this is not very clear. So this is something that there's a gray area. So there they kind of ran a Bayesian evidence synthesis and they have kind of estimated, okay, these are the probabilities that the person may be in one state and then goes to the other state. So these are all estimated values. Then comes the cost. Okay, cost again is usually based on government data. So we have this ministry, they saw this, the health ministry in Brazil. So they looked at the different costs of each, each therapy, there is a monthly cost, and they kind of multiplied that. Then costs were adjusted for differential timing. So this is another important thing. So we need to think about this discount rate. So what is something closely related to inflation, where what is your purchasing power of the amount? So now if you have 80,000, 10 years down the line, it may not still remain to be 80,000, it may kind of come down. So we have to kind of account for that. That is called discounting. And then, okay, so this is all looked at different direct costs, but probably not looked at the indirect costs as well. This is how, the probabilities and the utilities that you have, how reliable are they and how strong is the evidence? Again, what is the perspective? They looked at clearly from a TB program perspective point of view. They looked at the ICERs, the trade-off between impaired health outcomes and the resources spent. And then they looked at the health numbers also, the improvement in the number of DALYs, number of TB cases, deaths, like I mentioned, and all adjusted to inflation in US dollars. So comes the second part of the judgment. So how applicable is it? And again, what are the sources of probability? So here we are in the decision tree, we are able to easily put the probabilities and kind of go back. Whereas in the Markov model, like I mentioned, the Excel sheet, in this one, it's slightly more complicated. So they have kind of given us the probabilities, but to run the model, it may be a little more, slightly more difficult, and we may need to add up, may need more biostats help. The important thing to note is that all probabilities should come to 1. So if you add all these things, so uninfected, latent class, everything comes to 100. So that is one important thing that we need to look. And we need to look at, okay, so they have mentioned multiple the rates for transmission from one state to the other. These are all kind of estimated values. And then we kind of validate it with a previous existing model that is there. So this McQuaid is another WHO model that is there and kind of made using multiple databases from like countries like Kenya, Bhutan, Indonesia. So somewhat similar to our background. And we look at whether the estimated values in the model kind of reflect these. So kind of like a validation check. Here we note that most of them seems to be fitting inside. So here is 12% is the cumulative incidence in the first 5 years, which kind of fits in with this value. So this is kind of show that the model kind of works and it may be relevant in our population. So always in a study, they should always mention these things. Like I mentioned, the costs, the effectiveness, what is the incremental cost, and then you're looking at the ICERs. Okay, so has the study reported all these things, and the ICER should be mentioned for, especially for those that were, which are dominant. So the effectiveness for a base case scenario, they said that out of 1,000 individuals, 120 would develop TB disease, and in the bracket is the confidence, uncertainty intervals. So 120 would develop TB disease, 13 would die due to it, and 432 DALYs would be there per 1,000 people. If you look at the tuberculin skin test with the 9-month isoniazid scenario, kind of from 120 it's come down to 28. From 13 deaths it's come to 3.7, and 126 DALYs were aborted as compared to the base case scenario. If you look at the IGRA, again similar, it seems to be effective. So there's 34 TB cases, 4.5 deaths, and 149 TB DALYs averted as compared to your base case scenario. So close to 30% reduction in lifetime TB cases, reduction in death, and 30% reduction in the DALYs averted. So what is the cost? Base case cost is around 99,000. And then subsequently everything else is in incremental cost as compared to the base case scenario. So here we notice that they have given the cost for each strategy, IGRA, 1 HP, IGRA. So if you look at the IGRA and 1 HP, the cost is around 44,000 more than the base case cost. Whereas if you look at TST and 3 HP, that seems to be the least cost. So $8,790 per 1,000 individuals. Okay, so that seems to be the least cost of all. And you're still getting 138 DALYs averted and significant amount of cases that are prevented as well, aborted that are there. So this is again a cost effectiveness claim. So this kind of gives us an idea of how cost effective. So this is no intervention. This would be if you decided not to screen anyone. Then on the x-axis we have the DALY averted for 200. We have maximum effectiveness. Whereas if you're going up from 0 to 60, you have the cost that is there. So as you're going this side, first thing to notice is that the lowest cost, most effective would be 3 HP. That is the rifampicin isoniazid with the tuberculin screen test. And as you're going up, then comes the 1 HP with tuberculin skin test. The most expensive, the highest cost, but most effective would be the 1 HP with the IGRA. So these interventions seems to kind of dominate because they're more higher answers. Okay, so you're looking at the cost and you're looking at how many DALYs are averted. So again, they have mentioned the ICERs specifically also for the ones that dominated. So the TST 3 HP was 242. So again, lower the ICER, the better, more cost effective it is. So the tuberculin skin test plus the 3 HP kind of had only a ICER of around 242, which is more cost effective. The 1 HP was again slightly higher. I'm not sure how that came there. It is slightly higher, even though it was only 1 HP, probably through other, I'm not sure exactly how that happened. Then you compare it with your base case. So again, as we mentioned earlier, what was your willingness to spend? So according to the previous study, around 8,000, if it was less than 8,000, all these models would be cost effective. So most of all these interventions seem to be cost effective. Then they looked at, I think Mercy had mentioned, when did they screen the patient? So if they screened the people as early as 25 years, then your cost was low, your ICERs were low. As you go up, screening it at much later date, then the cost goes up. So around 65 years, ICER goes up to $1,000. So similarly, for the time spent in prison, the longer you stayed in prison, again, the ICER was, it kind of plateaus here. So initially the ICER, if you spend only 1 month, so you had gone for were in prison for only 2 months, then the ICER would be quite high. Then as if you spend for 1 year, again, ICER would be slightly higher. Then from 2.5 onwards, it kind of plateaus. So it doesn't make much of a difference later on. And this is your uncertainty interval. And similarly, the time between release and testing. So if you test immediately after release, it's kind of cost effective. As you go on later, it kind of becomes less cost effective and the uncertainty interval is quite wide. So ultimately, where do you think that the intervention lies? Does any of the registrars want to say, where do you think, which plane, which quadrant would it lie?
You are going to do an additional screening and additional treatment. Will it come at an increased cost? Same cost. Increased cost. So cost is definitely high. Is the effectiveness, is it effective? Less effective. Effective. So effectiveness is also high. So which
quadrant do you think? Yeah, so it will come here. So now whether you would actually implement this would depend on your country's willingness to pay. It saw that Brazil up to 9,000, 8,000 they said is willing to pay. So then, okay, they may consider this intervention. Okay, so willingness to pay is something that's important. So here we have again willing to pay would be around here. This is the shaded area, and these are multiple interventions that are there. So if you're willing to pay this much, the most effective thing would be green dotted line, which is here. That is 3 HP and the tuberculin skin test. So that would be most cost effective. But suppose you are not willing to spend that much, you want to spend only this much. Thing would be most cost effective. So it depends. So you kind of look at this graph and see what your willingness to spend and what is the maximum thing that is lying there. So as your willingness goes up, intervention again the cost effectiveness kind of goes down. So I'll compare that to our scenario as well. Yeah.
So in the gray, we were looking for which intervention has the highest probability of being cost effective within that.
Yes.
We did not look at we don't want it to be cheaper because we can spend within that.
Yeah, which is so your question is within that shading area which is better. Yeah, depends on your willingness to pay. So sometimes your willingness to pay, for example, if it is much lower, then you look at that area which is which has the highest probability of being cost effective, and then you would use that. So how robust are your results? So that's again looking at your sensitivity analysis. Yeah, so there are multiple ways of doing a sensitivity analysis. One is a deterministic model where you change only one parameter and you see how it changes the other results. And you can do a multiple variables you change at the same time, see how it changes, or you can kind of use a comprehensive model using a probability method. So they did a one-way deterministic model, and they looked at some few things that they looked at is, okay, if the person went again to prison, then how would the rates change? Okay, so then we get something called a tornado model. So this is useful in deterministic approach, and the ones which has maximum uncertainty are kind of on the top, whereas lower, the variables on the bottom are relatively more stable. So your dotted line is kind of your base outcome, and then you have loss or gain based on either side of it. So for example, let's assume so the things that had maximum was these things. So TB disease progression. Let's look at TB specific mortality. Okay, so if your TB specific mortality was higher, then the whole DALI and the ICER diagram will kind of move this side. So it would be more cost effective. Whereas if your TB specific mortality was quite low, so you were in, for example, some Scandinavian country, then doing this study may not doing this intervention may not really because the ICER will kind of push to this side. So it kind of looks at which is the more unstable kind of outcome and how robust are your results. Okay. So as per the study, what they found is the results are largely insensitive. So even though they ran it through multiple one-way sensitivity analysis, it did not cross that threshold of 8,000. However, they didn't do a probability related sensitivity analysis. That's something that we look at. So this is from the supplementary. So this is all the different things that they looked at. So progression rate, TB specific mortality, what is the cause? So as we see here, on top of the things that could have made the maximum difference, and here, even if the costs are different from our scenario, it doesn't really make a big difference because it hardly moves the overall ICER result. So ultimately, what we always want to know is, are the results applicable to our patient? So yes, in Brazil, actually, they also receive the BCG vaccine. They have similar diabetic rates or they're immunosuppressed. They use a similar tuberculosis skin test cutoff. Prisoners in India may be 5 times more, as I mentioned earlier, as compared to Brazil, and socio-economic factors may vary or may be slightly the same. So you can't kind of consider that BCG is a confounder. So kind of similar, and we have some data from Indian countries as well. So the model should technically work in our scenario as well. So currently, what does our Indian government recommend? So they recommend screening for those with HIV, those who are household contacts of pulmonary TB if they're more than 5 years, those who are planned for immunosuppressive therapy, silicosis. Doesn't really mention anything about patients who are going for incarceration. So we should be use a screening strategy followed by preventive therapy is what we're looking at. So they had looked at 3 HP, though that is rifampicin, which is quite expensive. We kind of, even though it's not a recommended regimen, we do use 3 months of isoniazid and rifampicin as well. So that's something that we can consider. So looking at what is the overall outcome that they looked at, I mean, the things that they didn't, like I mentioned, was they didn't look at the adverse effects, possibility of disease transmission, they did not consider, and they did look at patient importance. So this again, the patient will be worried, okay, does it improve survival or not? That's ultimately what they were thinking about. So how does these costs reflect to our CMC costs? So the cost of the IGRA is around 3,200 in US if you convert this $38 US to INR. It's somewhat comparable. Maybe the cost of an X-ray is slightly less. Tuberculin skin test also is slightly less in our scenario. If you're looking at cost of the 3 monthly, I'm talking about rifampicin, it comes to 912. If it's rifampicin, it's much higher. And then cost of the diagnosis is 2,900, which is 4,600, which is kind of similar, not very different. As cost, it would be a shared decision making. In our scenario, we are kind of talking about out-of-pocket expenses. Patients willing to pay. So, okay, is he willing to pay for all the treatment testing and all? So around 4,127. So this is, I mean, you our per capita GDP from, I mean, Brazil is all the way in 8,900. Ours is around 2,400. And that similar table showed that India willingness, I mean, for one GDP to be awarded, the cost should be around 2,000 US dollars, as compared to 8,000 in Brazil. So ultimately, that is equal to around 22,000 INR. So ultimately, will you go ahead and do it is the question. So how does the sense, I mean, if you apply this model to our population has a higher specific TB mortality rate. The cost also is, blue means low. So the cost is also less, cost of diagnosis is also less, cost of the tuberculin skin test is also less. So this ICER diagram, the ICER should actually kind of go lower for us and be more cost effective for us. Probably one thing that's going on that side is the number of defaulters. We have probably lower defaulters. That's one thing as compared to. So what would be our willingness to pay? So our willingness to pay would be somewhere around here. So if you're thinking about here, so if it's around 200 and you're looking at ICER is going to be, it's a difficult decision to make. Okay, so either you decide, I mean, don't screen, or you can do the tuberculin skin test. So ultimately, so you kind of find out cost effectiveness. That's one. So here depends on your willingness to treat. The next part of it is when you're having a budget meeting. So the health ministry will decide, do we actually have that much money in our bank? So around 5 lakh prisoners are there in India. So if you multiply close to 4,000, which is the cost of all our testing, we have 200 crores. We come to 200 crores. So do we actually have that 200 crores to spend is another thing. So cost effectiveness does not necessarily mean affordable. Okay, so that 200 crores comes to around 0.02% of our how much money that we are allocating to our healthcare. Okay, the government allocates to healthcare. So would we want to use this for TB screening or some other intervention that has a better ICER is what we are looking at. Okay, so probably it's a difficult decision to make whether to do this. Probably we could run the same model in our scenario with the same probabilities and all, then we'll have a clearer idea. And if suddenly the government decides that okay, they're going to spend more money for TB, then probably it may be cost effective. That's something that we can consider. Sure. So these are some of the resources that look at. There's a wonderful health economics course in our own YouTube website, and then the Mayo Clinic website that I use for the critical appraisal. Thank you very much.